Hi, my name is Chris King, and I'm the Assistant Clerkship Director for the Hospitalized Adult Care Clerkship. This video is an introduction to reading chest x-rays, which will provide a systematic approach for you to be able to read chest x-rays, which we will then practice at orientation on Monday. The objectives of this talk are that you will be able to identify the markers of chest x-ray quality, and that you will be able to understand the systematic approach to reading a chest x-ray. So what does make a good chest x-ray? First, you have to make sure that you have the right film. You have to identify what type of chest x-ray you're looking at, and you have to look for the markers of a good quality film. Those are that it's developed properly, that it has good penetration, and that the patient is not rotated. So first, let's look at what type of x-ray we actually have. And there are two types that we tend to see in the hospital. One is a PA, or posterior anterior back to front chest x-ray, which is usually accompanied by a lateral chest x-ray in which we shoot the film from one side to the other. This is the best quality film because it tends to distort the anatomy of the chest the least. Unfortunately, some patients aren't able to stand up to get this film, and so we have to do an anterior-posterior AP, or front-to-back chest x-ray, which does tend to distort the size of the heart and other anatomic structures in the chest. On a very rare occasion, sometimes we'll want to look at fluid within the chest, and we'll shoot what's called a lateral decubitus film, in which we have the patient lay on their side, and then we take an x-ray to see if the fluid is mobile. Those are the major types of x-rays that you'll encounter in the inpatient setting. So if you're looking at a picture, how can you tell whether or not it's a good picture? And the answer lies in three things. The first is the penetration good? And in order to get an idea for how good the penetration is, I want you to take a look at these two films. The one on the left is actually a PA, posterior anterior back to front chest x-ray. The one on the right is an AP, anterior posterior front to back chest x-ray. And you can see that the one on the right has a lot more white to it. It just seems hazy. Whereas the one on the left does not seem to have as much haziness. And where we tend to look to make sure that we have a good objective sign of this is at the spinous processes right here. If you look at the spinous processes, you should be able to follow them down, all the way down through the heart. Now you can see it's difficult to see the spinous processes down here, but I can make out the vertebral bodies. Whereas when you compare it to the film on the right, the anterior-posterior film, you can see that by the time that you reach down into about the middle of the thoracic spine, it becomes very hard to tell what spinous processes, where they are, how far down they're going, etc. So we would say that the penetration on the film on the left is better than the film on the right. The next thing that we look at is whether or not the patient is rotated. And to do that, we look at a couple of things. First is the clavicles. You can see that this patient's clavicles on the left are very straight, whereas the ones on the right tend to be more at an angle, which suggests that this film was not shot straight on the right. On the left, you can also see that these spinous processes that we were looking at earlier, if you draw a line down there, you can see that that forms a nice cross. Now over here, you can see that that's not quite the case. And what you really want to look at is on these clavicular heads, does that line that we just drew go right down the middle of them? And you can see that on both of these, the answer is it's pretty close to right down the middle. There's maybe a little bit of rotation on the film on the left, and maybe a little bit of rotation on the film on the right, in opposite directions, I might add. The last point I'll make is that this is a film of the same exact patient, so you can see how much variation there is depending on the film technique. Now that we know how good our film is, we can actually read our film, and luckily reading is as simple as knowing the alphabet. So we start off with the airway. The A is for airway, and what that means is the trachea, which I'm outlining right here, which goes down and meets up with the mainstem bronchi, which you can make out. It's a little difficult on this film, but you can make it out right there. And right here is the carina. The carina is an important structure to know because it gives us an idea of, do the mainstem bronchi go at the right angles? If they had an endotracheal tube, you would want to see how far away it is from the carina. You also want to see that the trachea is straight, it's not deviated in any way, and that there are no masses in it, which this film does not have. Since the airways are normal, we can move on to the bones. And in the bones, there's many different things that we're looking at, and sometimes this is where people can overlook things the most. There's a lot of bones in the thorax, and we want to make sure that the clavicles, right here, are normal, not fractured. When you look at the shoulders, yes, even out all the way out to the side here, you want to make sure that they're in the joint, the humerus is in the joint, and there's no dislocation. Then we look at the ribs. And when we look at the ribs, one of the things people tend to miss is that the first rib is actually this guy right here. Pretty tricky. But you want to make sure that there's a good amount of ribs to signify that the patient took a good deep breath for this x-ray. So we have 1, 2 up here, 3, 4, 5, 6, 7, 8, 9, 10. You can see the 11th one here, but we count down to the first one that hits the diaphragm. 10 is a good number. 9 to 10 ribs is a pretty good inspiratory effort. If it starts to get more than 11, then you start to think that they have hyperexpanded lungs. When looking at the ribs, you also want to make sure that you don't see any fractures. Looking at all these ribs, I don't see any fractures. And you can even make out the scapula right here, which looks completely normal on both sides. After we're done with the bones, we can move on to the cardiomediastinum, which also has a lot going on in it. The heart is probably the thing that first comes to mind, being as it's the first part of the word. So let's look at the right side of the heart here. The right heart border is right here, and you can tell that it's very clear, very normal looking. If there was any indistinctness to that border, it would suggest an infiltrate laying right up against that side. When we look at the left side, there should be 4 moguls that you see. The first one is right here. It's the aortic arch. Then the pulmonary artery. It's not very well defined on this x-ray, but the left atrium sits right here. And then finally, the left ventricle. Now you can see that those 4 moguls are all very clear. There's no haziness to that border, so there's no infiltrate laying up against that side either. The heart looks to be normal in size, meaning that it's less than 1/2 of the chest. And you can see that there are no masses in the rest of the mediastinum. After C comes D, which is the diaphragms. When we're looking at the diaphragms, there's a couple of things that we want to look for. You have 2 diaphragms, the one on the right side here, the one on the left side here. The one on the right side tends to ride a little bit higher just because the liver is right underneath it. On this film, they are about the same height though. The border is very clear. I can easily make out the border all the way across on both sides. There's no air under the diaphragm except for right here, and this is actually normal. This is what's called the gastric bubble, which is the amount of air that's sitting in your stomach. It's a normal finding, but otherwise air underneath the diaphragms is abnormal and usually an emergency. Now we can move on to looking for effusions, which flows naturally from looking at the diaphragms, because most of the time when we're looking at effusions, it's going to be a pleural effusion, which you would see a meniscus that would go right here. And that would suggest that there's a pleural effusion right there. This would be an instance where you could get a decubitus film to look and see if this fluid moves or if it's stuck or loculated. The other type of effusion that we can see is a pericardial effusion, and what that will tend to do is make the heart look really big and globby. And so it would make the heart come out here. Now sometimes it can be a little difficult to tell whether or not you're looking at just cardiomegaly or a pericardial effusion. But a pericardial effusion tends to make the heart look really lobular and just not of a normal size. So once we've looked for all the fluid that might be in the chest, we move on to the thing that everyone jumps to first. And I want to point out that this is the last thing we look at so that we don't miss anything else. The last thing that we look at is the lung fields. There's a couple of things to point out. One, the lung fields in this chest x-ray are very normal. Take a look at this vasculature that you can see. When you look right out in this area, you can see that the vasculature tends to taper out, and it's hard to see all the way out here. It, in general, should be about 2/3 of the way out from the center out to the chest wall is normal. If it goes all the way out to the end, then that's suggestive of heart failure, pulmonary edema, increased pressure within the vasculature. The other thing that you can look for is if this area is completely dark, meaning there's nothing in there, you can see a little bit of haziness here. If that's gone, that's concerning for a pneumothorax. Finally, you look for infiltrates. And when you're looking for infiltrates, there's two kinds. One is going to be very cloudy, and that's an alveolar filling process, meaning it's filling up the airways. It's going to look like a white fluffy cloud. The other one is going to be lacy or reticular, and that's an interstitial infiltrate, which is more of a problem with the actual pulmonary cells themselves rather than filling up of the airways. So those are the two different types of infiltrate that you'll see on your chest x-ray. That's all that there is to it. As long as you can remember A through F, you'll be a pro at reading chest x-rays in no time. So on Monday, what we're going to do is we'll practice. And as long as you keep the systematic approach in mind, you guys will do great. Always make sure to read every chest x-ray on your patients when you're on the medicine floor, and any other floor for that matter. The only way to get good at this is through practice, practice, practice. So we'll start that process on Monday. If you have any questions that came up while you were watching this video, write them down, bring them to orientation. We'll go over a bunch of practice x-rays. We'll give you guys a chance to ask questions. I'll make sure that you guys have a good understanding of what the heck's going on when we look at these pictures. And that's all there is. You guys will be pros by the end of the day. Thanks, and see you on Monday.